Hello, and welcome to the Frailty Seminar Series. My name is Sara Espinoza. I am a geriatrician and frailty researcher at University of Texas Health Science Center, San Antonio. And I have the pleasure of introducing Dr. Dennis Villareal today for our Frailty Seminar Series today. Dr. Villareal will be presenting his talk, Lifestyle, Hormonal, and Anabolic Interventions to Ameliorate Frailty. And a little bit of information about Dr. Villareal. He is Professor of Medicine in the Division of Endocrinology, Diabetes, and Metabolism at Baylor College of Medicine in Houston, Texas. And he's also staff physician at the DeBakey VA Medical Center in Houston, Texas, and he is faculty associate at the Huffington Center on Aging in Houston. He is a physician investigator with extensive both clinical experience in endocrinology and geriatrics, and also extensive research experience in examining the impact of lifestyle interventions on frailty in older adults with obesity. He was leading author of the American Society of Nutrition and the Obesity Society's joint position statement in obesity management in older adults. He has completed and is undertaking several randomized controlled trials, fostering an interdisciplinary team approach that demonstrates the importance of lifestyle therapies in reversing metabolic and physical complications of aging through clinical and translational research methods. He is a safety medical officer and sits on several NIH data and safety monitoring boards, and is also a member of the Clinical Trials Advisory Panel for the National Institute on Aging. Dr. Villareal is a dedicated research scientist, and his goal is to inform practice guidelines with regards to optimal treatment strategies for healthy lifestyle in older adults. His research is funded by NIH, VA Office of Research and Development, and American Diabetes Association. So we are very happy to have Dr. Villareal present his work today. He will be giving a talk for approximately 45 minutes, followed by Q&A. And if you have a question for Dr. Villareal, please put it in the Q&A. And I would also like to remind you that following the presentation today, you will get an email link to provide feedback evaluation. And then I would also just like to quickly plug our upcoming seminar in May, which will be Dr. Romero Ortuño from Ireland on May 11th, 2022. Okay. Without further delay, I thank you, Dr. Villareal, and please go ahead and get started.
Okay, I'm going to share my screen. Very good. Thank you, Sara and Kokoy and the rest of the organizers for inviting me to give this talk on lifestyle, hormonal, and anabolic interventions to ameliorate frailty. All right. Here's an outline of topics to be covered in my presentation. I will start with frailty interventions in older adults in general, and then focus on lifestyle interventions to ameliorate frailty in the increasing population of older adults with obesity. Why use lifestyle intervention to prevent or reverse frailty? Well, frailty could be due to unhealthy lifestyles and therefore due to treatable lifestyle factors. For example, undernutrition leading to protein deficiency, overnutrition leading to sarcopenic obesity, or sedentary lifestyle leading to exercise deficiency. Lifestyle factors are more controllable than systemic changes in the body, such as inflammation, oxidative stress, and decline in hormones. Lifestyle intervention could be defined as any intervention that includes diet, exercise, or other components such as counseling, stress management, or behavioral therapy, and especially comprehensive lifestyle interventions. Dietary factors during aging that contribute to frailty include inadequate protein intake from loss of appetite or gastrointestinal issues, the so-called anorexia of aging, reduced anabolic response to nutrients due to insulin resistance, higher splanchnic extraction, or possibly skewed distribution of protein intake. Accordingly, some experts, including scientific societies, have recommended that older adults should consume 1 to 1.2 kilograms of protein per day. The patterns of intake may be important, and there may be a threshold for maximum stimulus of muscle protein synthesis. Concomitant with aging, there is a decline in physical activity from 50% meeting the PA guidelines in the 65 to 75 years down to 25 to 30% in the 85 years. The decline in physical activity with age is associated with decreases in measures of exercise capacity, about 1% per year decline in VO2 peak, and 3% per year decline in muscle strength, which predisposes to frailty. The decline in VO2 peak is due to decreases in cardiac output, muscle oxidative capacity, and metabolically active muscle, while the decline in muscle strength is due to selective loss of type 2 muscle fibers and loss of neuronal activation, both of which can be treated with aerobic and resistance exercise. There have been several systemic reviews or meta-analysis of interventions to prevent or reduce frailty. The general inclusion criteria have been age 65 years or more, identified as pre-frail or frail, and usually involving 10 to 20 distinct randomized controlled trials, up to 5,000 patients. The main findings were that frailty interventions, including exercise, nutrition, and multi-component strategies, are included, though findings to date have been mixed. Exercise programs were shown to be generally effective for reducing frailty, but only when conducted in groups. Favorable effects were also observed for exercise with supplementation, supplementation alone, cognitive training, and combined treatment. Multi-component exercises of 5 months or more, performed 3 times per week for 30 to 45 minutes, generally had superior outcomes than other exercise programs. These are representative clinical trials. The LIFE-P trial conducted in the US showed that a physical activity program reduced the prevalence and number of frailty criteria. The trial by Nang et al. In Singapore showed that nutritional, cognitive, physical, and their combination interventions were each effective in decreasing frailty. The trial by Cameron et al. In Australia demonstrated that a multifactorial intervention involving dietitians, psychologists, and physiotherapists also reduced frailty. Of note, none of the frailty interventions specifically enrolled older adults with obesity. Despite that, more than a third of persons 65 years of age or older in the United States and likely elsewhere are now considered obese, and this group constitutes a population particularly vulnerable to adverse outcomes because obesity exacerbates the age-related decline in physical function, which can lead to disability. In fact, sarcopenic obesity has been appropriately characterized as the confluence of two epidemics, namely the aging of the population and rising rates of obesity. Accordingly, we first reported that although older adults with obesity had the largest amount of muscle mass, they also had the poorest muscle quality, probably in part due to muscle fat infiltration. In another study, those with a BMI of 30 or more had the greatest proportion of being classified as pre-frail or frail. The fat frail is considered to have the worst of both worlds as they age, not only having abdominal or visceral obesity, but also increased weakness due to sarcopenia, with a need for more muscle mass to carry greater body weight due to obesity. As you can see, the already small muscle mass has lots of fat infiltration, which is typical of the thigh MRIs of participants in our lifestyle intervention studies. Because of reduced physical mobility, older adults with obesity are more likely to fall during activities with little momentum, and the absence of soft tissue in the ankle and leg, together with a high impact of the fall, makes these sites more vulnerable. The findings of increased risk for ankle and lower leg fractures in older women with obesity in the GLOW study has also been shown in older men with obesity in the Mr. Oz study. So can weight loss and exercise ameliorate frailty in older adults with obesity? It was once commonly thought that it may be too late in life to change ingrown lifelong diet and physical activity habits. However, we first reported in a randomized controlled trial that obese older adults look forward to the weekly diet and exercise session, which resulted in clinically important weight loss. The treatment group was prescribed a balanced diet to provide an energy deficit of approximately 750 kilocalories per day and containing 1 gram per kilogram of protein. Total calorie intake was adjusted to prevent more than a 1.5% loss of body weight per week, with a goal of 10% weight loss at the completion of the study. Participants met weekly as a group with a study dietitian experienced in behavioral therapy to receive standard strategies to modify their behavior. The treatment group also participated in group exercise training on 3 non-consecutive days a week at our facility. The exercises were led by a physical therapist and included 15 minutes of flexibility, 30 minutes each of progressive endurance and resistance exercise at moderate to high intensity, and 15 minutes balanced exercises during the cool down period. The main findings were that 6 months of diet and exercise therapy compared to control significantly improved scores in the physical performance tests and peak VO2, which were accompanied by improved subjective ability to function. While obesity causes insulin resistance, not all develop diabetes because of compensatory hyperinsulinemia. We assessed pancreatic endocrine secretion during a 5-hour glucose tolerance test with C-peptide modeling and calculation of the disposition index. We found that diet and exercise improved beta cell function, which was attributed to an improvement in the static disposition index with no change in the dynamic disposition index. However, what we were afraid of also happened. Diet-induced weight loss, even when combined with exercise, decreased bone mineral density at the hip, as accompanied by up to 100% increase in biochemical markers of bone turnover. Based on our preliminary findings and review of the literature, we came up with a joint position statement for the American Society for Nutrition and the Obesity Society in 2005. The current data show that weight loss therapy improves physical function, quality of life, and the medical complications associated with obesity in older persons. Weight loss therapy that minimizes muscle and bone losses is recommended for older persons who are obese and have functional impairments or medical complications that can benefit from weight loss. In older adults, improving physical function and quality of life may be the most important goals of therapy. However, these guidelines were interim recommendations and could change as further research and information became available. Accordingly, we next performed a randomized controlled trial to determine the independent and combined effects of diet and exercise on physical function in older adults with obesity. We randomized 107 older adults with obesity and frailty to control diet alone, exercise alone, or the combination of diet and exercise. As shown here, diet and exercise induce similar 10% weight loss at 6 months, and this weight loss was maintained till the end of the study at 1 year. Whereas exercise training, similar to the control, did not change body weight. We found that diet alone and exercise alone each improved physical performance test score and the peak oxygen consumption. But the greatest improvement occurred in response to the combination of diet and exercise. Importantly, despite that diet alone reduced muscle mass, as I will show later, diet still improved physical function. In fact, not only were there no adverse effects of diet-induced weight loss on muscle strength, but also there were additive effects of diet and exercise on dynamic balance, static balance, and gait speed. Although losses of weight and fat mass were equal between the diet and diet exercise group, the diet exercise group lost less fat-free mass than the diet group. Despite the loss of fat-free mass, the diet plus exercise group had a 40% increase in strength, similar to the exercise alone group that gained fat-free mass, while the diet alone group had no change in strength, suggesting improvement in muscle quality. This is an MRI of the thigh in a participant randomized to diet-induced weight loss without exercise. After 1 year, participant lost 20 kilograms of body weight, which was comprised of 15 kilograms of fat and 5 kilograms of lean mass based on DEXA. Participant lost 10% of thigh muscle volume based on MRI. Despite the loss of muscle mass, the physical performance test score increased from 30 at baseline to almost a perfect score of 35 at the end of the study, consistent with reversal of frailty. This participant got randomized to the combination of diet and exercise. After 1 year, participant lost approximately 10 kilograms of body weight, which was almost all comprised of fat based on DEXA. Based on MRI, participant in fact gained about 5% of thigh muscle volume. Participant had quite a low PPT score of 25 at baseline, which also significantly increased at completion of the 1 year study. Based on sampling of skeletal muscles, we found that exercise, but not diet, suppressed the expression of interleukin-6 and tumor necrosis factor, while increasing the expression of mechanical growth factor, which is an isoform of IGF-1, indicating the importance of adding exercise to diet to decrease catabolism and increase anabolism within skeletal muscles. Regarding the independent effects of diet and exercise in bone health, we found that diet increased markers of bone turnover and decreased bone mineral density at the hip, while exercise did the opposite effect. Exercise decreased markers of bone turnover associated with increase in hip BMD. Accordingly, the addition of exercise to diet prevented the increase in bone turnover induced by weight loss and attenuated the weight loss induced decrease in hip BMD. In the stepwise multiple regression analysis, we found that changes in lean body mass, osteocalcin, and strength were the independent predictors of the changes in hip BMD, whereas the decline in estrogen due to weight loss was excluded from the final model. Interestingly, the changes in thigh muscle volume assessed by MRI follow the changes in hip BMD assessed by DEXA. Moreover, exercise attenuated the weight loss-induced reduction of muscle in a manner similar to exercise attenuated the weight loss-induced reduction in bone mineral density. Indeed, the changes in thigh muscle volume predicted bone mineral density response to lifestyle therapy in frail, obese older adults, highlighting important muscle-bone interactions during the lifestyle interventions. A possible mechanism for the osteoprotective effect of exercise during caloric restriction is that the increase in sclerostin, a protein secreted by osteocytes to decrease bone formation by osteoblasts during states of skeletal unloading such as weight loss, is prevented by the addition of exercise to diet. Here we examine the independent effects of lifestyle change by either diet or exercise on insulin sensitivity. Again, this shows that exercise had no effect on weight, similar to the control, whereas diet and diet exercise produced equivalent 10% weight loss at 6 months, which was maintained at 1 year. Accordingly, in the first 6 months, diet and diet exercise produced equivalent 40% improvement in insulin sensitivity, indicating an effect attributed solely to the diet. Whereas during The subsequent 6 months, when weight was stable, only the diet exercise group had a further 30% improvement in insulin sensitivity, indicating an effect attributed solely to exercise. Therefore, exercise effect on insulin sensitivity may be contingent upon proceeding weight loss in this population. Diet and exercise each also improve cognitive functions, as assessed here by the MMSE, word fluency, trail A or B. But the combination of diet and exercise provided benefits equivalent to those of exercise alone. With regards to quality of life, we found that not only diet and exercise each improved domains such as self-esteem, public distress, and work, but also the interventions resulted in additive effects on overall sense of well-being. In summary, diet but not exercise reduces body weight. Diet and exercise have additive effects on improving physical function, fat mass, quality of life, and cardiovascular risk. Whereas diet and exercise have opposite effects on fat mass and bone density. Diet and exercise each improve cognitive function, but without additive effects. Importantly, exercise does not prevent, but attenuates the weight loss-induced decrease in muscle and bone mass. Which raises the question, which distinct type of physical exercise is most efficacious in preventing the weight loss-induced reduction in muscle and bone mass and reversing frailty in older adults with obesity? We have shown that exercise attenuated but did not eliminate the weight loss-induced reduction of muscle and bone mass. However, the physiologic adaptations to aerobic and resistance exercise are distinctly different, which may interfere with each other when the two types of training are performed together. Therefore, in 160 older adults with obesity, we directly compared the effectiveness of aerobic, resistance exercise, or their combination in reversing frailty and preserving muscle and bone mass during weight loss. As shown here, the matched 10% weight loss across the three groups facilitated the assessment of the independent and combined effects of aerobic and resistance training. We found that despite a negative energy balance, aerobic training improved peak oxygen consumption, and resistance training improved strength. Thus, the combination of aerobic and resistance training improved aerobic capacity to the same extent as aerobic training alone, and improved strength to the same extent as resistance training alone, indicating with no interference effect. Therefore, the combination of aerobic and resistance training resulted in additive effects that translated into the greatest improvement among the interventions in physical function and reduction of frailty. Both resistance training and combined resistance and aerobic training attenuated the loss of lean mass that occurred during aerobic training. Moreover, although only resistance training prevented the weight loss-induced reduction in bone mineral density at the total hip, combined aerobic and resistance training nonetheless attenuated the loss of BMD at the total hip during aerobic training. We also recently reported that although aerobic resistance and combined exercise equally reduce abdominal and thigh subcutaneous adipose tissue during dieting, the combination of aerobic and resistance exercise was most effective in improving ectopic fat, namely abdominal visceral adipose tissue and thigh intermuscular adipose tissue that was associated with the largest improvement in insulin sensitivity index. To examine the underlying mechanisms for the relative preservation of muscle mass, we measured the rate of muscle protein synthesis in response to the anabolic stimuli of feeding by using stable isotope tracers during serial muscle sampling. We found that the response of muscle protein synthesis to anabolic stimuli increased more in the resistance group and combined group compared to the control group. There was also a better preservation of myocyte enhancing factor expression in the resistance and combined groups, greater reduction of autophagy mediator expression in the combined group, and a greater increase in mitochondrial activity, including creatine kinase and fusion fission expression in the aerobic group. Moreover, the aerobic group experienced a higher increase in the activities of the key enzymes involved in the citric acid flux and mitochondrial electron transport system. We found that compared to the aerobic group, the relative preservation of BMD in the resistance and combined exercise group was associated with less weight loss induced increase in CTX and PYNP, both markers of bone turnover. In the stepwise multiple regression, the independent predictors of change in hip BMD were changes in whole body mass and leptin. Therefore, both resistance and combined aerobic and resistance exercise may be recommended to protect against bone loss during weight loss therapy of older adults with obesity. What about long-term maintenance of weight loss after lifestyle intervention? At 30 months, we found that body weight was still lower than before intervention, and the changes in physical function were mirror images of the changes in weight. However, in contrast to BMD lost that tracked the weight loss during the lifestyle intervention, BMD loss continued to progress in opposite direction to the weight changes, arguing against the notion that bone loss during weight loss may be physiologic. However, perhaps if lifestyle intervention improves bone quality despite a decline in BMD by decreasing inflammation, it may not necessarily increase the risk of fractures. We are examining this hypothesis through a randomized controlled trial by evaluating changes in bone microarchitecture using HRPQCT, bone strength using finite element analysis, and bone material properties using microindentation. As mentioned earlier, some experts and societies have recommended protein intake higher than the RDA of 0.8 grams per kilogram per day in older adults. However, Apovian and colleagues recently demonstrated that exceeding the RDA, 1.3 grams per kilogram per day, does not increase lean body mass, nor does it increase physical performance above and beyond that in response to testosterone. Therefore, the RDA for protein is sufficient to maintain lean body mass in functionally limited older men who are not engaged in dietary restriction or exercise training. On the other hand, based on the recent meta-analysis by Hudson et al., the RDA for protein of 0.8 kilogram per day may no longer be appropriate during catabolic or anabolic stressors. As shown here, during energy restriction, protein intake greater than the RDA attenuated lean body mass loss by 0.36 kilograms, and during resistance training, increased lean body mass by 0.77 kilogram relative to consuming the RDA. Ensuring adequate protein intake might also help to preserve BMD during caloric restriction-induced weight loss. In postmenopausal women with obesity, a higher protein intake, 24% of total calories, compared to normal protein intake, 18% of total calories during caloric restriction, attenuated bone loss at the distal radius, lumbar spine, and hip that was associated with an increase in IGF-1. With regards to anabolic hormones, testosterone is well known to improve muscle mass and strength. In the trial of older men with mobility limitations, the TOM trial, the proportion of men achieving the minimally important difference in strength and stair climbing power was significantly greater in those receiving testosterone than placebo. In the testosterone trials, the 6-minute walk distance test improved more in testosterone than in placebo among all men enrolled in the study and in men not enrolled in the physical function trial. Moreover, the physical function component of the SF-36 questionnaire improved more in the testosterone than in placebo in both those enrolled and not enrolled in the physical function trial. Therefore, we performed a randomized controlled trial to determine whether testosterone replacement would augment the effects of intensive lifestyle intervention in older men with obesity and hypogonadism. In addition to being older and obese, participants had to have persistently low AM testosterone and evidence of physical frailty. They were randomized to lifestyle therapy, diet and exercise training, plus either placebo or testosterone. As shown here, lifestyle interventions resulted in mean weight loss of 9% in both groups at study completion. Testosterone and free testosterone levels increased more in the lifestyle plus testosterone group than the lifestyle and testosterone plus placebo group into the mid-young range for young individuals. Estradiol and estrone levels also increased in the lifestyle plus testosterone group due to testosterone aromatization, while estrogen levels decreased modestly in the lifestyle testosterone plus placebo group due to decreased aromatization from fat loss. We found that the addition of testosterone to lifestyle therapy did not further improve the score in the physical performance test, nor muscle strength, with both groups improving by 20 to 25% from baseline values. However, importantly, testosterone attenuated the weight loss-induced reduction of lean body mass as measured by DEXA and thigh muscle volume as measured by MRI. Testosterone also completely abrogated the weight loss-induced reduction in hip bone mineral density and augmented the lifestyle-induced improvement in VO2 peak by about 10%. As we know, VO2 peak is the best indicator of aerobic fitness and is a robust predictor of healthy lifestyle, of healthy lifespan in the elderly. Furthermore, we found that testosterone augmented the positive effects of lifestyle intervention on cognitive functions, such as attention and memory, which translated into further improvement in global cognitive function. Thus, in this high-risk population of older men with obesity and hypogonadism, testosterone appears to improve cognitive function with lifestyle behaviors controlled by lifestyle interventions. Of course, any potential benefits of testosterone need to be weighed against potential side effects. Several anabolic hormones and pharmacologic agents are currently being investigated, though primarily for the treatment indication of sarcopenia, which has an ICD-10 code. To name a few, these include myostatin antibodies, SERMs such as inosubam, ghrelin agonists such as anamorilin, activin antagonists such as bimagrumab, MAS receptors such as sarconius, and natural compounds such as ursocholic acid and tomatidine or urolithin A. And lastly, repurposed AMP activators such as metformin. The first four agents generally have been shown to increase lean body mass or muscle mass, but not necessarily improving muscle strength or physical function by only modestly or inconsistently improving them. A recently completed phase 2 study of MAS receptor agonist sarconius seems to show promising results with respect to gait speed at the highest dose. Studies with natural compounds are mostly preclinical or very early human clinical trials, also showing encouraging results. Bimagrumab may be worth highlighting because of its unique mechanism of action via blockage of the activin type 2 receptor. In a phase 2 study, 180 participants with sarcopenia based on low gait speed and low skeletal mass were randomized to monthly bimagrumab or placebo while receiving home-based exercise and nutritional supplements. Indeed, lean mass significantly increased in the bimagrumab group compared to placebo. However, physical function did not improve more in bimagrumab compared to placebo. It was concluded, therefore, that drugs that exclusively promote muscle hypertrophy, that is, without the neuromuscular and metabolic effects of exercise, may not be sufficient monotherapy to improve functional performance. On the other hand, another study involving 78 participants with diabetes and obesity randomized to monthly bimagrumab or placebo while receiving diet and exercise counseling revealed these findings. Interestingly, bimagrumab resulted in a substantial decrease in fat mass of 8 kilograms, while lean mass also decreased in the bimagrumab group compared to placebo, associated with improved A1C. These initial findings might raise the possibility for a therapeutic role in sarcopenic obesity, especially when combined with lifestyle intervention. In summary, in older adults with obesity and frailty, diet-induced weight loss, but not exercise-induced weight loss, decreases muscle and bone mass. Exercise added to diet attenuates the weight loss induced decrease in muscle and bone mass and further increases physical function by increasing muscle protein synthesis and improving muscle quality, and by decreasing bone turnover through enhanced skeletal loading and decreasing sclerostin. Protein supplementation may modestly preserve muscle and bone mass during weight loss, possibly through increasing IGF-1. Additional strategies to preserve muscle and bone mass during weight loss may include increasing the efficiency of protein intake, increasing weight-bearing exercise, and perhaps anabolic hormone therapy. Because of the multifactorial nature of frailty, multifactorial interventions or combined interventions are likely to be the most successful in ameliorating frailty. Thank you very much for your attention. I'm grateful to our participants and collaborators and our funding support from the NIH, ADA, and VA Office of Research and Development.
Thank you. Thank you very much, Dr. Villareal. That was a very sweeping, broad overview of very complex problems. I appreciate that. We don't have any questions in the Q&A box. I do see that there are a few people with hands raised, but I'm not sure if they're able to ask a question. Dr. Ruiz, is that possible? Oh, wait, we have a question in the box, sorry, in the nick of time. The question is from Diana Madrid. What do we know about the effect of types of exercise and muscle quality?
Both of them improve muscle quality in different ways. So, well, muscle quality is defined in different terms. If you divide the strength by the muscle mass, that's muscle quality, and you can define that that way. And I was highlighting that even though muscle mass decreased, there was a paradoxical no change in muscle strength or even improvement in muscle quality, which we attributed to the effects of exercise. And I would say it's a complex thing. So if it's aerobic exercise, it improves muscle quality by improving mitochondrial function. And if it's resistance exercise, it improves muscle quality by improving muscle protein synthesis. And both of them can decrease muscle inflammation. And don't forget about increase in neuromuscular activation. During early response to exercise, there are no changes in muscle mass, but there are dramatic improvement in muscle strength, and that's attributed to increase in neuromuscular activity, and that's also due to improved muscle quality in response to exercise.
Okay, thank you. We have another question. For the diet intervention, have you considered the oral conditions of the participants? Oral conditions, I'm assuming dentition or maybe even chewing ability. So oral conditions may determine the capacity of the person to take advantage of a quality diet. Is that's the question.
That's a very good question. We did not specifically consider that, and we had assumed that they would be able to comply with the dietary restriction. They're all obese, and apparently they're eating more than what they need. So not in this particular study, but that is really very important when you're doing nutritional supplementation in the other spectrum of the frailty, the underweight. Our goal here was to restrict calories, and that would in fact help us to induce caloric restriction.
Thank you. I think a follow-up question was, what about the quality of the diet? I'm not sure I understand the question, but I think they're asking the quality of the food intake.
Right. So again, we're dealing here with obese people that are overnourished. Okay. And so undernutrition is not a problem. We are doing caloric restriction. We're prescribed a balanced diet, and we ensured adequate protein intake. And as I mentioned, during catabolic stress, we need more protein. So we ensure that they would at least ingest 1 gram per kilogram of protein of high biologic value. And we also were careful that they would not be deficient in calcium and vitamin D. If I failed to mention, we did supplement them with multivitamins and calcium so that they met the RDA requirements for calcium and vitamin D. We didn't use any specific type of diet, such as Mediterranean diet or other things. This is a balanced diet.
Okay, thank you. We have another question from Swari Harada. Thank you very much for the thorough lecture. The diet and exercise therapy in your presentation decreased bone mineral density and increased bone turnover, even with prolonged effect. I thought resistance exercise should be protective for maintaining bone mineral density. Is this result implying that the effect of diet or weight loss on bone mineral density is greater than the effect of resistance exercise? If so,
I didn't quite get the last statement. Sarah, could you repeat that? The last clause you said?
sure. It says, is this result implying that the effect of diet or weight loss on bone mineral density is greater than the effect of resistance exercise?
Okay. Yeah, I would say it's impossible to completely eliminate the skeletal unloading induced by caloric restriction. And as I mentioned, it increases the sclerostin there. And so we're only able to attenuate it. We're not able to completely prevent it. That's the question, is whether the benefit of the caloric restriction outweighs the modest decrease in bone mineral density, and whether that translates into increased risk of fracture. And that's something that you need to weigh. They improve their physical function, they're less frail, their tendency to fall is less, they improve their strength from the exercise. So that might outweigh the small, modest decrease in bone mineral density. And again, somebody would also even argue that they start with relatively higher bone mineral density. And that's, again, a topic of controversy, because the bone quality might be also not so good because of the obesity and increased inflammation. So you got to weigh both of this. In my opinion, the benefit of the lifestyle intervention in improving their physical function, reducing their frailty, outweighs the modest decrease in bone mineral density.
Okay, thank you. Sort of a follow-up to that, there was a question, a sort of additional, about whether the speed of weight loss has an effect on the bone mineral density. Like if you have rapid weight loss, I assume.
It's actually the amount of weight loss. The amount of bone mineral density loss is proportionate to the amount of weight loss.
Okay.
In our caloric restriction studies, we also did this in the young people. We have a cutoff of, I think, so when I did this trial, our data and safety monitoring board required that if they lost 50% of their body weight, we have to do a DEXA to determine how much muscle mass loss they had and how much bone mineral density loss they had. And so it's more of the amount. I have not looked at the speed, but if the speed is fast, then the amount of weight loss is also a lot. And so
Okay.
they're both, yeah, so.
They kind of go together.
Yeah, if we go beyond that 10% of weight loss, and that's an area that needs further study, yeah.
Okay, we have a few more questions, but we have about 5 more minutes. Next question is, Excellent talk. I would like to hear if there are any ongoing randomized controlled trials looking at the combined effects of sarcopenia drugs plus exercise, for example, progressive resistance training in frail older adults or those living in nursing homes.
I have not reviewed the clinicaltrials.org. I suspect there might be. I can't mention any specific one. Maybe there is. Do you know, Sara?
In nursing home patients,
Oh, nursing home patients.
not that I know of, but there may be in frail. I think I have seen some exercise interventions for frail, but to my knowledge, they don't combine with drugs. They're mostly only exercise interventions. But yeah, that's the knowledge I have, which is not as much as our expert. Okay, next question was, I was wondering, what is your thought on bariatric surgery on physical function in older adults, particularly as patients age? What does it mean for patients years down the road, I guess years after bariatric surgery, and the role of diet and exercise post-op for these patients to maintain strength and muscle mass?
Again, that needs investigation. In general, older adults that are relatively functional probably should not be ruled out as candidates for bariatric surgery, although in our VA they are ruled out. So bariatric surgery might have some specific role in people who are relatively healthy and obese, and I assume that would dramatically improve their physical function. But the trade-off also is bariatric surgery causes more weight loss, and there might be more lean body mass loss and bone mineral density loss. And again, related to your question, the more they need to have adequate protein intake and adequate exercise, resistance exercise. I hope that answers the question.
Yes.
In elderly, there's not much studies. There might be some case reports there, but in younger people there are, and it's important, as we know, that bariatric surgery, as I tell my patients, is not a cure. They have to change their lifestyle and not wait to regain, because that could happen, and it's worse because they regain the fat. They don't regain the muscle and bone that they lost. They only regain their fat, and that's worse than before they lost weight.
Right. Okay, and last question, which is the take-home message about testosterone that testosterone in frail patients should only be recommended when patients have persistent low testosterone levels?
I didn't want to recommend anything on testosterone. That's very controversial. I'm just showing you my study. Our study was a small study, and in general, testosterone, not just in general in all older obese, the Endocrine Society guidelines indicate that you give testosterone in people who have persistently low AM testosterone, and I think the cutoff there was 264 by LCMS, and that should be done early AM, and it should be associated with hypogonadal symptoms. Our participants had hypogonadal symptoms, which we call frailty, and they also had persistently low AM testosterone. So when it was low the first time, we repeated it because testosterone levels could fluctuate. And those might be the candidates for this kind of intervention. But you gotta individualize it because of the adverse effects of testosterone. I think that's a diverse study. They're still looking at whether it increases or not amazed, right?
Okay, yes, thank you. Okay, well, again, I want to thank you, Dr. Villareal, for a very broad and interesting talk, and we appreciate your time and expertise.
Thank you for the honor to present here. Appreciate it.
Thank you. And thank you all for joining. Goodbye.